I know that a lot of pediatricians have concerns about motor delay in the many children that they see. And so one of the purposes of this talk is to understand the importance of surveillance for neuromotor screening. We want to understand and recognize the signs which indicate a cause for motor delay, and also recognize specific syndromes which can cause delayed motor development. It's important to recognize the signs of a motor delay because this may be the first sign of a disability in the child, a global developmental disorder, a neuromuscular disorder, or another developmental disorder. It's important to recognize signs of a motor delay because making the diagnosis of a developmental or neuromuscular disorder might be very important for the family planning and also for the future educational planning of the child, as well as the health of the child. So, what is a motor delay? Motor delays are impairments in both the tone or the strength or the motor control or motor planning of a child. And motor planning refers to the child's ability to organize a task. So it might be something very complicated like trying to tie a shoelace, or it might be something simple like trying to grab onto a fork. As I said before, motor delays are very common, and the implications of a motor delay can be quite severe. What I'm going to talk to you about now is the American Academy of Pediatrics Screening Algorithm. Pediatricians often encounter delays in motor development, and this American Academy of Pediatrics Screening Algorithm was designed by a multidisciplinary panel created to make it easier for pediatricians and to have a more systematized approach to looking at developmental delay. Now, as we go through this development, this algorithm, which is quite confusing, I'm going to highlight various points as we go through. So the first thing is that the child comes to the pediatrician for a visit, and that's point 1 up here, and they're key screening visits that we always look at. And typically, it's recommended that you do developmental screening for motor disorders at 9, 18, 30, and 40-month visits. So the developmental surveillance is done, and if there are certain concerns that are identified, then we go to a different point in the algorithm, and we start the pathway down on how to evaluate those concerns. So further developmental screening can be done, and typically that can be done either by the parent in terms of a form, or the nurse can help fill out a developmental screening tool, or the medical assistant. Also, the physician will need to get an expanded history and examination. And one of the points of my talk today is to go over that expanded history and examination. So if the history and exam is concerning, then we're going to proceed ahead. And this algorithm, then the next decision point is there an abnormality in tone? And we'll go over what abnormalities in tone can look like, and then make a decision about whether any imaging or blood testing needs to be done. Now, if a child does have abnormalities, typically we bring in early intervention, and a referral may be made to a consultant, whether it's a developmental pediatrician or a neurologist. And then the diagnosis of a developmental disorder can be made. So this screening algorithm is found in Pediatrics, and there's a wonderful article that relates to it and goes through the whole algorithm, and I would recommend that that's reviewed if you want to learn more about this. So as I said before, we're going to go through concerns around screening, the history and exam, tone issues, and what tests and when to order them. So I'm going to briefly review some motor milestones now. Typical motor milestones. For example, at age 2, we're going to go through each age, the gross motor milestone, and the fine motor milestone. At age 2 months of age, a baby could just lift their head to midline and lift their chest in the prone position. Fine motor movements are typically symmetric, but there's not a lot of fine motor movements that we'll see. The baby will grasp on something, and the grasps should be fairly symmetric with each hand. At 4 months of age, the baby will roll over and support themselves on their elbows or on their wrists. They have an unfisted, their hands will be unfisted, and they can grasp, and they'll bring their fingers to midline. At 6 months, the baby can sit without support, typically, and reach, transfer objects, and have a raking grasp. At 9 months, the baby will pull to stand, crawl, and roll, and has a 3-finger pickup. And then at 12 months, a child can walk, typically stand, and bang objects together, put a block in a cup, and have a 2-finger pincer grip. And you usually will check that by you picking up a Cheerio or something similar. So at 15 months, the child typically can walk backward, is starting to run, and will scribble with a pen in imitation. And at 18 months, start to walk upstairs holding onto a hand, build a tower of 2, and scribble spontaneously. At 2 years of age, the child will ride on a toy and can build a 3-block tower or train. At 3 years of age, a child will climb alternating their feet and can ride a tricycle with pedals. They'll build a 4-block tower or train and imitate both a horizontal and vertical line. And then at 4, the child will climb without support up the stairs, hop on 1 foot, draw a 6-part person, and draw a cross. So those are some typical motor milestones, but what are the red flags that I think about, or that a neurologist might think about, or that I'd like you to think about? At 3 months of age, if a child is already rolling, that would imply to me that there's an abnormality in tone on one side of the body or some weakness. Because if one side of the body can move and the other side can't, the child will roll. So that's abnormal if the child is rolling at 3 months. And then at 4 to 5 months, if a child has poor head control and still can't bring their head up to midline, that would be a concern. At 6 months, if the child isn't rolling, that's also a concern. And if the child has head lag. Now at 9 months, one abnormality of too much tone is scissoring, when the legs are really tight together when the child is lifted up. Also, if the child has persistent primitive reflexes, and we'll go over the reflexes later. At 12 months, when the child should be walking, if the child doesn't have any protective reflexes, such as putting out their hand if they're going to fall to the front, side, or back, then that would be a red flag. At 15 months, walking on your toes is a concern. And at 18 months, if the child has already developed a right-handedness or left-handedness, or is not walking, both of those are concerns. If the child is right-handed or left-handed, that would imply that the other side of the body is not functioning properly, and that would be a cause for concern. If the child is not walking, of course, by 18 months, we're also concerned. So how to talk to the family about this, what to ask in the office. Is there any delays in skills? Well, there are a couple of good questions to ask. Is there anything that the child is not doing that he or she should? Is there anything that other children do that are not difficult for your child? Are there atypical movements? Anything that your child is doing that concerns you? Or is there regression? Any skills that your child used to do and can no longer do? Further questions to ask in the history relate to the pregnancy, fetal development, neonatal period, and delivery. So with the pregnancy, we'd want to ask about maternal illness, maternal medications, any injuries during the pregnancy, In the fetal, for the fetus, was there polyhydramnios or abnormal fetal movements or no fetal movements? Was there a short cord upon delivery? What was the position of the baby? During the delivery, was there any birth trauma? Were the APGAR scores abnormally low? And did the baby need resuscitation? And then in the neonatal period, was there any weakness or other signs that were concerning? Did the baby need assistance with breathing or feeding? Did they notice the baby was dysmorphic or had any other concerns? I always ask when the child went home with the mother, because that gives me an idea if there were concerns of the hospital that they would keep the baby longer. So we also like to ask questions about the family history. For example, consanguinity. Are the parents related? Because that can be a sign that there's an increased likelihood of a recessive disorder. Are any family members affected? Is there a brother, a cousin, an aunt or uncle, or a parent who has a similar dysfunction or had similar delays as a child? And then are there any signs in the parents that might be very mild but would be important to know about, because that might give us clues as to what's going on for the child? So for example, if the parent walks on their toes, that might be a clue to me that the adult might have some leg weakness and that we should look for an inherited disorder like a muscular dystrophy. Or if there's stiffness, the parent can't open up their hands properly. They feel stiff all the time. That might indicate that there's a myotonic dystrophy, which can present much more severely with weakness and hypotonia in the child. Scapular winging might present in an adult as just a mild concern about how it looks, but in the child it could be presenting much more severely as facial weakness in facioscapulohumeral muscular dystrophy. Ptosis in the adult might also present in the child and be a sign that there's a myasthenia. And ligamentous laxity in the adult can be presenting much more severely as ligamentous laxity in the child, which would cause low tone. So some of them could be quite severe, and some of them could be quite mild or reassuring. So what I'd like to do now is go over an anatomical approach to motor delay. So when I think, as a neurologist, when I think about a child who has a delay, I think about the brain, the spinal cord, the lower motor nerve, and the neuromuscular junction and muscle. So the upper motor nerve starts in the brain, in the prefrontal cortex, and it goes down through the spinal cord, and there it will synapse with a lower motor nerve and go all the way to the neuromuscular junction, where it will synapse with the muscle. And so we can have a disorder in any one of these areas: the brain, the spinal cord, the lower motor nerve, the neuromuscular junction, or muscle. So what kind of difficulties can we see? Well, in the upper motor nerve, we can see spasticity. In the spinal cord, we can see marked flaccidity, and if there's a spinal cord lesion or trauma to the spinal cord, we can see sometimes spasticity below that. Lower motor neuron disease can typically cause a lot of weakness, but the weakness is spared in the eye muscles and often in the diaphragm or sphincter. Neuromuscular junction disorders, right here, those often cause ptosis, difficulties with extraocular movements, and difficulties with suck and swallow. And muscle disorders will often cause weakness in the proximal muscles of the limb and cause facial weakness. The physical examination for a neurologist is like being a detective. It's really important to observe the child when they're not stressed. So I like to watch the family walking into the room. If possible, play with toys And then, because the exam changes a lot when a child is stressed, it's often good to see when the child is angry, because then you get a real sense for what their muscle strength is. Because angry children will show you their strength. So I'll start with the head when I examine a child, and I look at the head circumference. So this child here is macrocephalic and has a large head. And sometimes that's just familial, but we also think about metabolic, genetic, or structural disorders that can cause large heads. Microcephalic children, like this one here, has a very small head, and that can be a genetic disorder. I also look for dysmorphism, evidence that there may be a genetic disorder. In the general examination, I'll look at the respiratory pattern. And that's important because if the child is tachypnic or using extra respiratory muscles, it will give me an idea that they're having some difficulties with their strength. And so I'll think about congenital myopathies and motor neuron diseases. I'll examine the abdomen to look for organomegaly because there's some glycogen storage diseases that present with a large liver. I look at the spine always because it's very important to look for pits in the spine or hair over the spine because that might give us clues about spinal dysraphism. And that's important especially in the child who isn't walking properly because they may just have an abnormality in their lower spine. In the limbs, it's very important that we look at the size of limbs. So I'll examine the fingernails of the hands and feet. And if one of them is much smaller than the other, that would give me a clue that there might be a congenital abnormality that's affecting the growth of that limb. And it could just be a stroke or cerebral palsy, but you can see often that there's a difference in the size. I also look at the shape of muscles. Children with a muscular dystrophy, they tend to have large muscles. And and then children who have Charcot-Marie-Tooth disease, like this child here, have very slim muscles. And as you can see, the arches are very high in these feet. And that's because there's atrophy of the muscle. So we're going to move on now to the neurological examination. And again, it's really important that you observe the child because children are not typically very cooperative, especially the under 5 population. So I'll look at the eyes of the child when they're coming in. And this child has ptosis. You can see that the eyelids are droopy. I also ask the children to close their eyes. And if they're not cooperative with me, I'll just bring my hand towards their eyes, and typically they close them. I like to see if they can bury their eyelashes. That gives me an idea about facial strength. Similarly, I'll wave a toy around in front of the child or look around and ask and see if the child follows me to get an idea of whether their eye movements are full. Disorders of eye muscle weakness or ptosis can be due to a neuromuscular junction defect or a disorder of muscle. And eye closure weakness is often a disorder of muscle. Similarly, if the eye movements are not conjugate or there's weakness, then we think about a disorder of the neuromuscular junction. So this little baby here, who's very cute, you can see has an asymmetric face. So right here, you can see that the nasolabial fold is quite prominent. And on the other side, the face is smooth. And I'm showing you that to show you that this child has probably a facial nerve palsy. So half the face doesn't have strength. And so the baby can't show any facial expression. So I also like to watch the baby crying because when the baby's crying, I don't like to watch them cry, but when the baby cries, I can get a better picture of that facial strength. And sometimes and you try to get the child to smile also, because when a child has a weak face, their smile looks more like a grimace. So instead of a big smile, it might be kind of a grimacy smile, because they just can't lift up the edges of their lips. So we try to get the baby to suck or drool, or I look to see if the child is drooling, because drooling would be a sign that the child has facial weakness. And I also look at tongue fasciculation. So that's a quivering tongue. And it's hard to do because you have to have the baby still with an open mouth, because usually they get angry when you try to open their mouth, but you look for quivering of their tongue. Also, blowing kisses or drinking through a straw are helpful in determining whether the child has facial weakness. So this child has a congenital myopathy, and you can see that they're hanging with they have their mouth open, and we call that a fish mouth. The child might not even be able to close his lips. But the important thing is, so asking them to blow a kiss would elicit that for you. Older children, asking them to whistle is helpful. So we look at the bulk of muscle, the bulk, strength, and tone of muscle. Low bulk, or atrophic muscle, is seen with lower motor neuron lesions. It's also seen when a child is not using their limb, then the limb atrophies, or you have disuse atrophy. Now, large bulk is seen with muscle disorders. In muscular dystrophies like Duchenne, we see pseudo-hypertrophy or false hypertrophy, because the muscle isn't strong, but it's big. In myotonia congenita, another muscle disorder, we see large muscles. And I've seen children who look almost like they're weightlifters. They're so bulky from their muscle disease. Normal bulk can be seen with upper motor neuron lesions. Sometimes with SMA, we see normal bulk as well. So now to go to muscle strength. Again, children are not inherently cooperative, so we have to try to trick them. With the infant, it's easier because we will hold a baby up and try to support its weight in a stand and see how they respond to anti-gravity movement, as this baby here. So it's a traction response, and the baby, you can see, is not able to lift its head off the table. So that would be a sign of weakness. The other thing to notice here is how the legs are splayed out. We call that a frog legs position, and the child is unable to bring their legs up into a natural position. The toddler, we want to watch them walking and standing, rising up from the floor, and holding their arms above their head, because they all can do that, and they're quite cooperative. I check for finger or grip strength by having them grab onto my fingers and trying to swing them or lift them up. And usually they're cooperative with that. For children over the age of 3, we'll ask them to try to do a push-up against the wall. And you can see this child here has scapular winging. Hopping on either leg can identify if one leg is weaker than the other. And we also ask them to climb stairs, because when they're climbing, you can see if they always lead with one leg, then there might be a leg weakness. So this is a child with proximal weakness. It's a Gower sign, and we see that in muscle disease, with muscular dystrophy, and with myositis, or an inflammation of the muscle. So the child is trying to get up off the floor, and as you can see, they don't have the thigh strength to get up without the use of their hands. So they put a hand on their knee, and then they sometimes will march the hands, like this child is, right up the knee and up the legs until they're standing. A child who has this sign probably can't get out of a chair without holding onto the arms and pushing up. So muscle tone. Infants who have low tone, well, first of all, what we like to do is watch how the baby is resting. And then we watch the baby with anger, because as I said, the anger brings out the muscle strength and kind of helps us to separate tone from strength. If the tone is increased, we'll think about an upper motor neuron lesion. And if the tone is decreased, we'll think about a lower motor neuron lesion. So this baby is held in horizontal suspension. And a typical baby would bring their head to midline and would bring their knees up to midline, or they'd bend their feet. So this baby has very low tone, kind of like an upside-down U. Similarly, in the traction response, pulling the baby up, we see that there's head lag. Now, premature babies who are less than 33 weeks gestation do not have a traction response. So they would respond just like this baby, and that's normal. And the baby should be able to maintain their head in line with the body by 1 month of age. So in the American Academy of Pediatrics article, there is this chart here for assessing the tone in the child. So I'll refer you to that. And it comes from a book written by Dubowitz and others. So the first picture here is of the scarf sign. And essentially, the scarf sign is a sign that helps us figure out tone in the shoulders. A normal scarf sign is if you bring your arm across the chest, and it can only go to midline before you start to feel resistance. If you bring the child's arm further than that, then that would be a sign of low tone. And if you can't bring it even to midline, that would be a sign of high tone. Another way to measure tone is in the knees, and you have the child lie prone with the hips and the knees at a 90-degree angle, and then you try to open up the legs, and you see how far up you can bring them. And a child with a large angle, or a child who's unable to lift their legs up at a 90-degree angle, would have increased tone. And a child who can bring their legs all the way up straight is a child who has decreased tone. And the details of that and the tone angles I'm going to leave for you to look up in this article. So next is reflexes. Now we look at primitive reflexes as well as protective reflexes in little children. For example, the Moreau reflex. That's when you lift up the baby and just about an inch or less, and then you let go, and the baby will bring their arms out symmetrically. That disappears at 2 weeks of age. A stepping reflex, where you hold the baby up and you touch the edge of their leg to the bed or table, should persist until 6 weeks, and they'll make a step. The rooting reflex persists until 4 months, and the palmar grasp also persists until 4 months. Now, the plantar response, or Babinski, where you stroke the bottom of the foot and the toes flay out, is normal to be flaying out or extensor up until about a year of time. If they're asymmetric, one goes up and the other goes down, that's concerning. So we both look for the presence of the reflexes and the disappearance of the reflexes. Protective reflexes, like the parachute reflex, when you hold a baby up as if they're a parachute and drop them down a little without letting go, they'll flay their arms out again. And that is a normal reflex that we all need when we are walking, because if we start to fall, we need to flay out our arms so we catch ourselves. And that starts at 6 or 7 months as the baby is starting to get up and cruise and start to walk. And there's other protective reflexes, anterior, lateral, and posterior, which help protect us if we're falling backwards or to the side. Now, when is the Babinski positive or upgoing? As I said before, it's positive before a year of age, and that's normal. And if there's an upper motor neuron lesion, so that's a lesion that would be in the spinal cord or in the brain, then we'll see a positive Babinski. So that can help us to figure out what's going on. So the deep tendon reflexes. So first of all, I say use a hammer when you check them. Don't use your finger, don't use the stethoscope, because you get a better reflex. And especially in a child with a developmental delay, you want to know, are the reflexes increased or decreased? So an increased reflex is seen with upper motor neuron lesion, and a decreased reflex is seen with a lower motor neuron lesion. And if there's a disorder of muscle we might not see a change in the reflexes. So what are some signs we see in muscle that can help us? So atrophy we talked about, that you don't usually see atrophy in upper motor neuron lesions. In lower motor neuron lesions, you see marked atrophy, and in muscle disease, you might not see any initially. Fasciculations we talked about of the tongue, for example, and you can see those in upper motor neuron lesions. You can see those in anterior horn lesions, and in muscle disease, you do not see them. Fasciculations are due to spontaneous firing of the lower motor neuron or spontaneous depolarizations of the lower motor neuron. Okay, so now we're going to move on. We've talked about the physical exam and the history, and we're going to talk about now, discuss common causes of motor delay or hypotonia. We'll start with cerebral palsy, then move to Duchenne muscular dystrophy, spinal muscular atrophy, and genetic disorders. So we're focusing on the diseases now instead of the physical exam findings. Now, cerebral palsy is a non-progressive, static neuromotor impairment. So it doesn't get worse over time. And that's important. Its causes can relate to pre, peri, or postnatal injury. It can be due to prematurity. It can be due to infection in utero or post-utero, hypoxia in utero or postnatally. It can be due to toxic causes or CNS injury. The diagnosis is made before age 2. So you have to see signs before age 2, but you can see hypotonia as well as hypertonia. Again, there's no regression with cerebral palsy, and it's more common in premature infants. 36% of babies born before 28 weeks of gestation will have some cerebral palsy, and 37% of babies with cerebral palsy were term babies. So the persistence of primary reflexes is quite common in babies with cerebral palsy. So that's a good clue to help us in diagnosis. And motor impairment is usually the primary manifestation of the cerebral palsy. 70% of children with cerebral palsy will also have an additional impairment. It might be intellectual, developmental delays, or some other extrapyramidal signs or movement disorders. Now, cerebral palsy is not always permanent, so that's very important. 20 to 30% of babies with mild impairments will resolve by the age of 7. So it's quite encouraging how babies' brains can repair. So the classification for cerebral palsy is based both on the type of dysfunction as well as the anatomic distribution. So we see spasticity, ataxic cerebral palsy, and dyskinetic cerebral palsy. And that's the cerebral palsy where you have the chorioathetotic movements. The anatomic distribution can be either a hemiplegia, so half the body, a diplegia, the lower part of the body, or quadriplegia involving all 4 limbs. Now, the diagnosis, according to the American Academy of according to the American Academy of Neurology practice parameter in 2004, is based on the history and examination, a screening for associated conditions such as hearing, orthopedic, speech, and feeding, and neuroimaging, if not already done. So I'll say this again later, but MRI is better than CT scan. I don't like to do CT scans in babies because it just gives them radiation. So think MRI. I say it again, imaging studies, MRI, not CT scan. Now, metabolic studies are sometimes done if there is no evidence of a stroke or injury or malformation in the MRI scan. Now, if there is evidence of a stroke, then we're going to proceed with other studies. And if there's no evidence of any structural abnormality, we'll check neonatal metabolic screening. If no specific etiology is found and the child has some regressions, then we may proceed more in the direction of looking for a metabolic disorder, especially if the family has a history of a CP-like disorder. It's important to remember also that we need to check thyroid function and, again, recheck that neonatal metabolic screen. Now, if the child did have evidence of a stroke, then we are going to look specifically for coagulation or clotting factors, but the child should be referred to a neurologist for that. The next disorder is Duchenne muscular dystrophy, and that's seen in 1 in 3,500 children in the U.S. It's an X-linked disorder. It's inherited from the mother of muscle protein, and dystrophin is the protein that's abnormal. A third of the cases are spontaneous mutations, and there are certain presenting signs that are important to be aware of. Difficulties walking, a waddling gait, the proximal muscle weakness with the Gowers that I showed you before, large calves, bulky muscles, delays in motor milestones, walking on their toes, and very importantly, sometimes a child comes in with elevated liver function testing. Now that elevation is often just due to the sky-high CPK testing or CPK results. So it's important to remember that if you have a child with very high liver function testing and they've got big-looking muscles, check the CPK because you might spare the child a liver biopsy. And I've had 2 kids in the past 3 years who actually had liver biopsies, and then it was found out that they had Duchenne muscular dystrophy. Muscular dystrophy has a progressive course of weakness. There are no effects on the bladder, bowel, or sensory neurons, but the child will progress, typically by the age of 12, to a non-ambulatory state. And cardiac muscle is also affected. So again, we make the diagnosis by checking a CPK test. And that can be elevated even pre-symptomatically in the child. Now, interestingly, we used to do muscle biopsies in these children. The first line is now genetic testing, but that will be the role of the neurologist. So treatment for muscular dystrophies is steroids, genetic trials, and supportive or preventative therapies. And that includes supportive therapies for breathing and ACE inhibitors for the difficulties with cardiac function. Spinal muscular atrophy is another disorder of infants and children that causes weakness and atrophy. That's caused by defects in a gene on chromosome 5q, the survival motor neuron gene, or SMN1 gene. And the protein that's encoded, SMN protein, is needed for the survival of motor neurons. Spinal muscular atrophy is quite frequent, relatively, and it's 1 in 6,000 to 10,000. And it's an autosomal recessive disease. And there are 4 types: an infantile type that never sits, an intermediate type where the child never learns to walk, type 3 has difficulties walking, and type 4, the symptoms only begin after the age of 30, and it's a slower progression. The presentation of spinal muscular atrophy is important, especially in the young children, because there's profound hypotonia. There's bulbar dysfunction, so there may be difficulties with swallowing, but the child actually has normal appearing extraocular movements and facial muscles. And there's tongue fasciculations and lack of reflexes, as I discussed before. In type 2 spinal muscular atrophy, it's a little bit milder. The child will fail to stand or walk, and you sometimes see finger fasciculations, and it looks like the child has a tremor. Sometimes there's pseudo-hypertrophy of the muscle, so the muscle might look normal bulk. In SMA3, after 18 months, the child will walk but might have difficulties with stairs. And it's slowly progressive, and the lower extremities are more affected, and there may or may not be pseudohypertrophy. In spinal muscular atrophy type 4, the adult onset It's quite like mimics type 3, but milder with onset in adulthood. So we're going to move on now to some genetic causes of neuromotor delay. Angelman syndrome and Prader-Willi syndrome both are related to the same chromosome, 15q11.2 to 13. Now, Angelman syndrome is inherited from the mother, and the child is very profoundly hypotonic, and we say happy puppet because they're often very floppy and quite agreeable in personality. They have ataxia and seizures, language delay, and global developmental delays. Prader-Willi syndrome is also notable for marked hypotonia, and there's marked developmental delays as well. The babies with Prader-Willi syndrome have feeding difficulties, but most of us think about Prader-Willi syndrome as the children get older because they get quite heavy, like this child here. But often the babies have feeding difficulties. Now, Angelman syndrome is inherited from the mother, and Prader-Willi syndrome is inherited from the father. And you can do DNA testing, but right now methylation studies are usually the first-line test if you suspect those disorders. Other genetic causes include Fragile X, which has marked hypotonia, cognitive delays, and boys are more affected than females, but sometimes female carriers can be affected, and there can be mild dysmorphism with large ears. Noonan syndrome is an autosomal dominant disorder with failure to thrive, and 75% of children with Noonan syndrome have failure to thrive, motor delays, hypotonia, and hypermobility. And they have cardiac disease with pulmonary stenosis and a bleeding disorder. And you can see this child has Noonan syndrome, and he has a large head, a short neck, and it's webbed, and a very high hairline in the front, and you can't see he has a low hairline in the back. Other genetic causes, Down syndrome or trisomy 21 has marked hypotonia, global developmental delays, and a characteristic facies and stature, which I suspect you're quite familiar with. Klinefelter syndrome also has motor delays, hypotonia, a language-based learning disability, and after age 5, we see evidence of the low testosterone, but before age 5, you don't see that. So other causes of delay. As I told you before, I'm a neurologist, so I think by system. Muscle disorders, we think about congenital myopathies, myotonic dystrophy, and metabolic myopathies. At the neuromuscular junction, we think about myasthenia and congenital myasthenia. Nerve disorders, we think about Charcot-Marie tooth disease. At the motor neuron level, we think about spinal muscular atrophy. And at the brain, we think about brain injury, cerebral dysgenesis, inborn errors of metabolism that affect the brain, and benign hypotonia, which is another form of non-malignant, just familial hypotonia. So other causes to think about that are very important are hypothyroidism and mitochondrial myopathies. So for take-home messages, I've reviewed the American Academy of Pediatrics Screening Algorithm, and I've discussed key elements of the history and family history. Remember those red flags that I talked about before for developmental milestones? I reviewed the anatomical approach to motor delays, the brain, spinal cord, upper motor neuron, lower motor neuron, neuromuscular junction, and muscle. And we reviewed the physical examination. We examined some common genetic syndromes with motor delay or hypotonia.